Dear colleagues, welcome to our third MENA GMPS Neuro joint webinar. My name is Doğa Vurallı. I'm an associate professor of neurology at Gazi University. My co-host, associate professor Esme Kizoğlu, will introduce our first speaker.
Dear colleagues, welcome to all. It's my pleasure to host this webinar with you, Doğa. Thank you. And it's my pleasure to invite our first speaker, Dr. Serkan Emekli. He is a neurologist actually at Istanbul University, Istanbul Faculty of Medicine, the Department of Neurology at CNS Immunological Disorders. And yeah, dear Serkan, the word is yours.
Hello, good evening, and thank you for kind introduction. So it's a pleasure to be with you tonight, and I will basically present a case for you. It's a complicated case of cerebral venous sinus thrombosis due to Behçet's disease, and I'm gonna also give you some brief introduction to vascular neuroBehçet's disease as well. So let me just. So this is a 58-year-old male patient, and he has a left hemicranial throbbing headache started a month ago. It's also associated with some nausea and vomiting, and there was like a suboptimal response to analgesia. In the recent week, he had also double vision when looking left, and we understand that he has a pleural thickening and had a biopsy which resulted as non-specific fibrosis a year ago. Other than this, he has no known diseases. So the neurological exam showed bilateral optic disc edema. It was consistent with papilledema, and he had also left lateral gaze palsy, consistent with CN6 palsy, and his visual acuity was good in the right eye and 0.8 in the left eye. So after we saw the papilledema and CN6 palsy, so we did the neuroimaging, which showed right transverse sinus thrombosis, left sigmoid sinus thrombosis, and the posterior portion of the superior sagittal sinus thrombosis. And there was no associated structural damage to brain parenchymal damage, no venous infarction, and no hemorrhages. But you can also see the transverse sinus and sagittal sinus thrombosis and sigmoid sinus thrombosis in the FLAIR sequences as hyperintense lesions in the venous area. So we did the rumbar puncture, which showed 42 centimeters of water opening pressure, and the closing pressure was 14. And there was also mild pleocytosis, which involved like 12 per millimeters cubic millimeter and 20 PML cells. And the CSF biochemistry was normal. Also, there was no associated microorganism was found, and cultures was sterile. So after we saw all these information, so we started anticoagulation to this patient. But the diagnostic studies also continued as a little bit older male patient. So we did a vasculitis panel, which was negative, protein CS antithrombin 3, and the prothrombic PM mutation and also factor V leader mutation was also negative. But we tried to deepen the history, and we also, we revealed some oral afts, but not so frequent as we would expect in a Behçet's patient. Also, he had some erythemanodosum-like lesions in the lower extremities in the recent years, and he had an episode of arthritis in the right knee joint, and also episode of folliculitis, and history of like one episode of promophlebotitis. So after all these, we also, consider the Behçet's disease in this patient, which is also the Behçet's disease is also kind of like an endemic in our region. So we sent HLA-B51, which was negative, which might be also consistent with Behçet's disease. So we also did a pathogen test, and which was positive, but no other signs of active Behçet's disease in this patient. So we would like to be sure about the Behçet's disease. So we retest about the pathology of this patient, but which was again also positive. So we did the diagnosis of cerebral sinus vein thrombosis due to Behçet's disease in this patient. And we started with high-dose IV methylprednisolone and also added oral methylprednisolone tapering to this patient. And as an immunosuppression, we started cyclophosphamide initially because he had also thrombophlebitis and signs of vascular Behçet's disease as well, in addition to the acetazolamide to reduce to increased intracranial pressure. And after 3 months of cyclophosphamide, we continued with the maintenance treatment with azathioprine. And in the meantime, so the headache continues, and the control neuroimaging also showed no recognition at the 6 months. So we considered that it might be like a treatment failure. So we switched the treatment from azathioprine to mycophenolate mofetil and did some workup to reveal that there is no arterial aneurysm. And then after we were sure, so we started anticoagulation to this patient as well. But at the 18 months, he still had somewhat headaches continues and not too much visual impairment, but the control CSF studies show that CSF opening pressure was still at the high end. So we switched back to cyclophosphamide for 6 months, but after the 6 months, he developed some impaired vision under cyclophosphamide treatment, which is very unlikely. And his visual acuity was 0.5 in the right eye and 0.4 in the left eye, and CSF opening pressure was higher at like 35 centimeters. And so we redo the imaging, and which showed there was like no recanalization in those thrombotic sinuses. And the visual fields show that there's like a peripheral field defect in addition to some central scotoma in the right eye as well. So we considered now to refer him to the lumboperitoneal shunt surgery, and after we did the surgery, the headaches resolved substantially, and after that, the visual impairment just stabilized, and treatment switched to infliximab for the next few years. And then after 2 years of stable disease, we switched back to mycophenolate mofetil, and he was stable after like 7-8 years with mycophenolate mofetil with no other episodes of neuroBehçet's disease. So this was a patient with vascular neuroBehçet's disease, but this is not the typical patient. So normally we would expect patient to respond very well to the immune treatment in cerebrovenous sinus thrombosis in Behçet's disease. So I'm going to talk a little bit about the vascular neuroBehçet's disease. So this is like a 20-30% of the neuroBehçet's, which is also like a 5% of the Behçet's disease. This is strongly associated with other vascular involvement. And so this is a very big study, a MENA study, which has like 108 Behçet's disease CVST patients, which show that these patients has like a subacute and chronic disease compared to the other causes of CVST, which was also like half of them is acute and like 85% of them is acute subacute. So this is like a one differential feature of vascular neuroBehçet's disease. This is like a subacute chronic disease. So when you compare the clinical findings, so you can see that isolated intracranial hypertension is almost exclusive in all patients with Behçet's disease, which is also significant when you compare with the non-BD patients. Papilledema is more frequent, and we almost never see like a focal neurological deficit, seizures, or any focal lesions. It's so rare to see a venous infarction and hemorrhage in vascular neuroBehçet's. So this is from one of our studies that we compared the CVST in Behçet's disease with other non-inflammatory CVSTs, which also showed that in all patients, transverse sinuses were affected. And other studies also confirmed that between the involvement of transverse sinuses were like 80 to 100%. So we did also a new thing to the thrombus probability map in Behçet's disease. So basically, we delineated all the thromboses in Behçet's disease patients and other CVST patients. So in Behçet's disease, like almost all patients had like transverse sinus stenosis, and like almost 20% of them has superior sagittal sinus thrombosis, but mostly in the posterior part of it. And we also generated a thrombus probability difference map of Behçet's versus non-Behçet CVSTs, which also showed this effect better. So in Behçet's disease patients, so there's like a 51% higher chance of involving transverse sinuses, while comparing with the non-BD, non-inflammatory sinus vein thrombosis, which has like 67% of increased probability of involving this superior sagittal sinus. So when we come back to the treatment of CVST, there is no specific randomized controlled trials. So mostly these are like expert opinions and like big cohorts. And the recommended treatment is IVMP for between like 3 to 10 days, and then oral tapering of methylprednisolone on 3 to 6 months in addition to do immunosuppressives. But the anticoagulation use is still controversial. There are some reasons opposing the use of anticoagulation. Is one of them is the pathophysiological mechanism is different, which is inflammation mainly in Behçet's. The thrombus is firmly attached to the wall, and the other reason is that anticoagulations may increase the major arterial aneurysm bleeding risk, which is one of the leading cause in mortality in Behçet's disease, pulmonary arterial aneurysms. So another systematic review showed that like almost 90% of these patients treated with steroids, 50% has steroids with immunosuppressants, like almost 74% have been anticoagulated in the acute term and 50% anticoagulated in the long term, which also show that there's like a controversial in this area. So most of the times the outcome is favorable, but in 20% of those cases there are like some sequela. So mostly these are like visual loss, and 80% has like optic atrophy. So there are some. So at the end, basically there are some specific features that you can distinguish Behçet's sinus vein thrombosis to the other causes of cerebral venous sinus thrombosis. But mostly you would expect a favorable outcome. But as the case that I presented, like 2 to 3% of those cases had like this much complicated, and you may need to do the shunt surgeries as well for these patients. Thank you so much. So basically this was my presentation, and I'll just let you introduce the next speaker.
Thank you, Tuncay. Actually, I have a question for you. In this patient, you performed lumbar puncture. Like in which patients with sinus venous thrombosis you perform lumbar puncture? When do you perform lumbar puncture in these patients?
So actually it depends. If you see like a venous infarction, a hemorrhage, and like any cause that intracranial pressure may cause like herniation, you wouldn't do that, basically the lumbar puncture. But in these patients, like we didn't see any tumoral lesion, and there was like no risk of herniation in this patient, but there was like a papilledema, and we would like to be sure that the pressure is how much the pressure is high, and also there was some issues about he was like a 58-year-old with no other associated or like any other reason to get a cerebral venous sinus thrombosis. So therefore, we would like to do the lumbar puncture to see the CSF profile, the biochemistry, and the cell profile as well. But in our clinic, we do like most of the patient if there is no hemorrhage and venous infarction to see where we are in the beginning.
You perform lumbar puncture. Okay.
Most of the times.
Can you also summarize, in this patient you saw papilledema, but if there were no papilledema, can you also summarize what were the headache features that may make you think that this can be a secondary headache case?
So in this patient, actually, there was like no, IIH like headache, no postural headaches, no morning headaches. It was like basically in the beginning you would expect like it was like a migrainous headache in this patient, but the age was not, the start of the headache age was not fit, didn't fit to the migraine, and also it was like a new headache in the last months. And in addition to that, he developed lateral gaze palsy, which is so very specific to the intracranial hypertension. But when you look at the fundus, so it's possible to not see the optic disc edema, uh, especially if there's like a grade 1 or 2 disc edema in those patients. So I would suggest that if there is a suspicion that increased intracranial pressure in these type of patients, I would suggest you to do an OCT scan to these patients. So you can easily show that there is RNFL thickening in these patients. But if you ask me about if there is like a difference in the headache type of Behçet CVSD patients and the other CVSD patients, I would say that I think there is now. So there is no specific features of headaches that make you suggest this is a Behçet's disease.
And we have also a question from the audience to Serkan. Thank you, Serkan, for this very nice case presentation. How could we describe the reason of papilledema of neuroBehçet disease CVT or tumor cerebri? I think, there's no in both of them we detect papilledema, but is there any other ocular finding that we may make this differential diagnosis, Serkan? Yeah.
Actually, there is no specific fundus finding that may tell you that this is due to pseudotumor cerebri or idiopathic intracranial hypertension or CVSD-related increased intracranial pressure. So basically, you will see the same fundus imaging, but the neuroimaging is the distinguishing feature in these patients. So you would expect some stenosis, but not thrombosis or like impairment in the blood flow in IIH or pseudotumor cerebri patients. But we exclusively show that the thrombosis in the spherosagittal sinus and transverse sinuses in this patient, but no differentiating specific features that you can see in the fundus.
And I think Professor Esra Cuman Demirel has a question.
Good evening. First of all, thanks for this great presentation. You said that use of anticoagulants is controversial, but do you prefer or do you use anticoagulants like these people, like the patients?
So normally, if a patient had a history of Behçet's disease and present with some cerebral venous sinus thrombosis, we almost never use anticoagulation if there is no like a complicated case of as this one, which showed no recanalization at the 6 month. So we normally start with IVMPs and then oral tapering of steroids and then add some immunosuppressives. Mostly now these days we add anti-TNF agents. But as this patient, he had no history of Behçet's disease. So we diagnosed him with Behçet's disease and neuroBehçet's disease almost at the same time. If there is like a no history of Behçet's disease, like this patient, so these are like 2 to 3% of the CVSD patients in Behçet's disease. So we started anticoagulation to this patient and then switched to the immunosuppression. But after had no response to those immunosuppressives. So we just basically screened the patient about the arterial aneurysms. And after we demonstrate that there is no aneurysms, we started anticoagulation back to this patient again. So, but normally in a routine case of CVSD in Behçet's disease patient, we almost never use anticoagulation these days.
Okay, thank you.
We have another question from the audience. Is optic nerve fenestration useful in this patient? Can it be useful in this patient?
Uh, this is another controversial thing that so you can use optic nerve sheath fenestration if there's like one eye is more involved than the other. But in this patient, the visual acuities in both eyes were impaired, and also we already started to see that the peripheral field defect and also central scotoma in this patient. So it's possible to use that optic nerve sheath fenestration, but at the same time, in this patient, the headaches are also were continued. So we know that the nerve sheath fenestration is not very helpful to the headaches. So we would like to have the um have some effect on both headache and papilledema and optic nerve atrophy in this patient. So we prefer the shunt surgery. And, and also it's really not easy to find surgeons to do the optic nerve sheath fenestration these days. This is another,
Okay.
restricted field.
Thank you, Tuncay. If we
Welcome.
have no more questions, I think we can go on. And I want to introduce Tuncay Gündüz. He's an associated professor of neurology at Istanbul University, Istanbul Faculty of Medicine, and he's an expert in central nervous system immunological disorders. Today, he will talk about Neuro-Behçet disease and headaches.
Good evening, everyone. Thank you, Doğa Vurallı and İsmet İzoğlu for kind invitation. And I want to thank Serkan for the wonderful talk, comprehensive and concise at the same time for a true hard case of CVST. Okay, today, I will talk about neuro-BHS disease and headache possible connections. But first of all, we should talk about Hulusi Behçet. In 1937, he described the etiology of uveitis, oral ulcers, and genital ulcers, comprising of Behçet's disease. But today, the mystery of the pathophysiological group classification still continues for Behçet's disease. So which disease group does Behçet's disease belongs to? Is it autoimmune in nature or autoinflammatory in nature? As you know, these two groups are different, have different components between them. So let's talk about the most important aspect of the neuro-BHS disease pathophysiology, interleukin-1, and the interleukin-1 associated autoinflammatory diseases. So as a short introduction, in the body, macrophages, neutrophils, endothelium, and epithelium continues to secrete pro-interleukin-1 beta and pro-interleukin-1 alpha intracellularly. And then once a pathogen or damage-associated molecular pattern, which are damage signals, arrives at the cellular surface, they trigger a response intracellularly, which involves mainly NLRP3 inflammasome complex. So this in turn converts pro-interleukin-1 beta to interleukin-1 beta. And after the release of interleukin-1 beta to the systemic circulation, it arrives to the effector cells, which are mainly endothelium and innate immune cells in this context. So interleukin-1 beta also at a less level, interleukin-1 alpha binds to the receptor, interleukin-1 receptor, cellular surface receptor. And in turn, this binding triggers nuclear factor kappa B activation intracellularly. Nuclear factor kappa B is a general inductor of inflammation, as you know. So this reaction causes production, and release of a bunch of inflammatory molecules, cytokines, chemokines, inflammatory enzymes, and adhesion molecules. We have a set of autoinflammatory diseases, as you know, hereditary autoinflammatory diseases. These patients have abnormal activation of the interleukin-1 beta pathway. So genetic activation, abnormal activation. You may have heard about these diseases. Mainly rheumatologists deals with diseases, but we are familiar all with FMF. So these diseases have a significant activation, abnormal activation of interleukin-1 beta. And therefore, when you administer interleukin-1 beta or alpha blocker medicines, drugs, you can cause significant clinical improvement in these patients. So why I am mentioning about that? We have an overlapping clinical findings in Behçet's disease and autoinflammatory diseases, hereditary autoinflammatory diseases. So in this figure, you can see all these involvement sites are shared between Behçet's disease and autoinflammatory diseases. So when you evaluate all these findings, so which disease group actually, Behçet's disease most likely belong to both groups. It has features from autoimmune diseases and autoinflammatory diseases. So why I mentioned about this pathophysiological process, as I will later talk about the headache associations of the Behçet's disease, Behçet's patients have an increased inflammatory innate immune system activation in their body. So primary headaches, for example, secondary headaches, headaches are secondary to the infection or inflammatory conditions are more likely seen in this patient. So this aspect of the pathophysiology may partly explain the increased prevalence of headache in the Behçet's patients. So let me talk about briefly clinical findings in Behçet's disease, not neuro-Behçet's yet, but Behçet's disease. So these patients may have oral ulcers, genital ulcers, and some other skin reactions, for example, papulopustular lesions and erythema nodosum. So these are the inflammatory lesions in the skin and purplish colored and very tender if you make some pressure on that. They may also occur in the feet also, as you can see here. So we may see also ocular findings. Anterior uveitis, most commonly we see uveitis. We are used to uveitis in the Behçet's patients, as you know, but also posterior uveitis, retinal vasculitis, branch retinal vein occlusion, optic neuropathy, which are some kind of rare in these Behçet's patients. Also, we can see cystoid macular edema. Not just uveitis, but also these pathologies may be encountered in the Behçet's patients' eyes. Vascular involvement, not just only in the brain, of course, but thrombophlebitis. Here is an ultrasonographic image of a thrombus, and arterial aneurysms, which may be dangerous for the patients who would be anticoagulated, as you know, and pulmonary artery thrombosis may be encountered. But also we see Budd-Chiari syndrome if the superior vein cava hepatic vein is occluded. And rare gastrointestinal symptoms, some believes it may not be present, but just like oral ulcers, mucosal ulcers, you may encounter ulcers in the gastrointestinal system, and which may cause anorexia, vomiting, dyspepsia, diarrhea, and abdominal pain. In 1990, as you know, BHS diagnostic criteria was released, and oral aphthous ulcers were sine qua non. Also, you should have two of these four findings: genital ulcers, eye involvement, skin involvement, and positive pathogen test. But in 2014, a point approach has been a point-based approach has been suggested, and in this criteria, neurological involvement was also present and take 1 point. So in all of these signs and symptoms, if you reach at least 4 points, you can make a diagnosis of BHS disease with a 94% of sensitivity and 92% of specificity. Okay. So neuro-BHS disease, Serkan mentioned about the vascular BHS disease. I will pass the part very fast, but 5 to 10% of BHS patients may encounter neurological involvement in later periods. NBD, neuro-BHS disease, NBD is more prevalent in males. The ratio is 2.8 to 4. And what kind of involvements we may see? 60% have parenchymal involvement, 38% cerebral, 17% maybe progressive, and 5% is spinal. 20%, as Serkan mentioned, has thrombosis, cerebral sinus vein thrombosis, and we also see rarer involvements, which may include pseudotumor cerebri, ischemic stroke, and 3% with MS. I will show some MRIs of these patients. Aseptic meningitis is also very intriguing diagnostic challenge in these patients. Optic neuropathy is also a rare finding, as we mentioned. Okay, so clinical phenotypes. I will show you some clinical findings and MRI findings. These are the typical MRI lesions, which involves mainly brainstem, mesodiencephalic region, also extending some upwards. So we call this image finding as cascade sign, and cascade sign, which is water is falling from the height to the lower parts of the brain. Okay, we think that the T2 hyperintensity here is mainly composed of edema. So when you make a contrast enhancement, when you make a contrast MRI, you may see a small part of the lesion is contrast enhancing. So when you administer corticosteroids at this period, so you see a rapid resolution of the lesion, fast resolution. So we think that most of this image finding is due to the edema of the inflammation. So a question arises at this point, and not yet answered that. Most common pontomesencephalic and diencephalic regions, and why? Why is that like that? So it may be caused due to different anatomical features of the venous structures in this area. We see symptoms, brainstem symptoms, and diencephalic involvement symptoms and findings in these patients, which may be diplopia, dysarthria, vertigo, cranial nerve palsy, and tendency to sleep and behavior change. And we may also detect, of course, relevant findings, eye movement defects, cerebral signs, cranial nerve dysfunction, cognitive dysfunction, also movement disorders, which are rare, but we may encounter that, hemichorea, hemibalismus, hemidystonia, and rarely epileptic seizures. In the acute period, as I mentioned, you see a T2 lesion in the brainstem, and the relevant, the most inflammatory part of this lesion is this little relevant to the little lesion, and contrast, peripheral contrast enhancing lesion. And 6 months later, you see an atrophy has occurred in the brainstem, which we encounter frequently after the initial episode, and it may increase. It may increase through the years. Atrophy may progress through the years. You may pass that. I think acute lesion histopathology. We see mononuclear cell infiltration, T lymphocytes and very few B lymphocytes, and we don't see. It may be worth to mention in the slide that we don't see vasculitis. In some resources, in some papers, the batches are mentioned about vasculitis, but we say that it is not vasculitis, it is perivasculitis. So the inflammation is mainly seen around the vascular structures, not in the walls of the vessels. In the CSF, we find a few hundred cells, lymphocyte or neutrophil predominance, which may be changed according to the phase you took the CSF, in acute or subacute phase. So you may see elevated protein levels and 15 to 20% oligoclonal bands. In the long term, you see atrophy of the brainstem. Here you see a typical presentation, an asymmetrical atrophy. This patient have first relapse, first attack in the right side of the pons, and this is the new one, left side. And you see the right side of the pons mesencephalon has been atrophied. This is the cascade sign image, and you can see the characteristic image finding. We see cognitive dysfunction in this patient, mainly frontal executive dysfunction in these patients, even though we don't see frontal lesions. And we hypothesize that this dysfunction is actually maybe due to disconnected pathways between brainstem and the frontal cortical areas. So you see dysfunction at both areas, which is called diachesis. So, but this is not has been proven yet, not yet, but we will work on about that. So frontal executive dysfunction will cause in the future personality change, reduced self-care, disinhibition, memory impairments, withdrawal, or even kleptomania. So we see frequently in these patients these symptoms, as I said. Okay. So this is a rare presentation, spinal involvement in neuroVHS disease. It may be heavy, it may cause significant sequelae, and with a very little response to the acute treatment. So I will pass cerebral sinus vein thrombosis. Okay, this is our patient. Yes, I can mention about that. Pseudotumor cerebri without vascular involvement, which is not different from the idiopathic pseudotumor cerebri cases. And if it is severe, you should treat vigorously, possibly also involving shunt. Okay, this group is an important and interesting group. Patients both have Behçet's disease and also MS. They have systemic Behçet's disease findings, also typical MS lesions and MS findings, also positive oligoclonal bands in their CSF. So Behçet's disease have an increased prevalence of MS in compared to the normal population. We don't know why, but it may be due to some kind of antigenic spread or antigenic exposure of the CNS proteins to the peripheral immune system. So you should treat these patients like MS, not neuro-Behçet's disease. I mean, you should give MS treatment from the very beginning. Okay. Aseptic meningitis, optic neuropathy, multiple involvement, and polyneuropathy comprises rarer phenotypes. We may pass these. Neuro-Behçet's disease may have this differential diagnostic table, and you should all consider these diseases when differentiating the Behçet's disease from other neurological disorders. In the acute periods, we give pulse steroids, 1 gram per day for 5 to 10 days, followed by 4 times weekly. And after that, for 6 months, we administer oral prednisolone with tapering, gradual tapering. And in the chronic period, we give immunosuppressants and immunomodulators, as Serkan mentioned. We also need symptomatic treatments because patients show, as I said, a lot of cognitive dysfunction symptoms or epilepsy, so you should treat accordingly. These are first line, second line, and third line treatment options, and we use in neuro-Behçet's disease. Or azathioprine, mycophenolate, and methotrexate are first line. Cyclophosphamide, infliximab is preferred in our center in second line. Nowadays, we prefer more infliximab. And the third, as a third line, tocilizumab, canakinumab, or anakinra may be chosen. And these are also more experimental medications. Okay, I can pass also this role of anticoagulation. We do not use anticoagulants mostly in CSVT. And in conclusion, in patients with Behçet's disease presenting with headaches, differential diagnosis should include sinus vein thrombosis, aseptic meningitis, or parenchymal neuro-Behçet involvement. And current research indicates that the prevalence of primary headaches may be increased among patients with Behçet's disease patients. Neuro-Behçet's disease and Behçet's disease are linked to a systemic inflammatory response, and which may likely account for the increased prevalence of primary headaches in this population. And in a patient with Behçet's disease who presents with a novel type or increased severity of headache, it is essential to first exclude sinus vein thrombosis or other neurological involvements. Okay, I would like to thank all my colleagues, and I would be happy to answer the questions. from now on.
Thank you, Tuncay, for the informative and comprehensive talk. There are two questions from the audience. First is, can a diagnosis of neurobehçet disease be made without a diagnosis of Behçet disease?
Okay, this is an interesting topic. Also, we are actively researching and considering. So we think it's possible. But first of all, I mentioned about the hereditary autoinflammatory disorders. So there are some patients which present with typical MRI and the neurological findings, cascade sign or something, brainstem lesions. So it's all neurobehçet, you can say. It's neurobehçet, but these patients may have in the past that periodic fever or some kind of rare or some kind of peculiar systemic findings, erythema or some kind of stomach ache, abdominal pain episodes. So in some of these patients, we detected some hereditary conditions, some mutations. So we changed diagnosis from Behçet disease, neurobehçet disease to other autoinflammatory disorders. But at the end, they are both treated with anti-TNF mostly. So the treatment generally doesn't change, but the diagnosis is important.
We have a question from Professor Esra Ciman Demirel.
Thanks for this great presentation. Thank you. You said that we can see cognitive symptoms. How do you treat cognitive symptoms for these patients? For example, I read somewhere that we can use memantine. Do you have any experience?
Yeah, it's a good question. We are generally not successful in treating of these symptoms, as you may guess. So, but we can suppress the excessive disinhibition or other agitated behaviors with antipsychotics. But generally, the anticholinergics like memantine or donepezil doesn't work because of the different pathophysiological processes. So not just involving acetylcholine pathway. But generally with low dose or moderate dose neuroleptics will work on these patients. Also, they may have some need of antidepressant treatment.
We have more questions from the audience. Esme, would you like to read?
Yeah, please. We have a question from Dr. Wael Alvachi. For how long we use IV immunosuppressants, and is there any biomarkers for following the activity? Tuncay.
Yes, that's also an excellent question. So the exact time is not now known at this time. But we may have some guesses about that. In our experience, parenchymal neurobehçet disease patients have second relapse within 7 years. And the sinus vein thrombosis patients have 5 years. Therefore, in our center, we give immunosuppressants for 10 years to parenchymal patients and 7 years to the sinus vein thrombosis patients. And after that, gradually taper the immunosuppressive and wait for the response if there is any relapse or some kind of progression. So, but in general, we don't see any relapses after that period.
And we have a question from Assistant Professor Samiye Ulutaş. Samiye.
Hi, thank you for great presentations. I wonder that you mentioned Behçet disorder is both autoinflammatory and autoimmune disorder. So I wonder that is there a pattern that dominant autoimmune or dominant autoinflammatory patterns for Behçet disease in your clinical practice or in the scientific background? Is it a pattern? If there is a pattern of dominancy with this, does this pattern affects your treatment? Yeah.
Well, okay, that's a good question. If I take a chance to answer that, Behçet disease has more autoinflammatory pattern. So, in a sense, when you give drugs which affect autoinflammatory pathways like anti-TNF, so anti-interleukin-1 alpha, they are very effective in HS patients. But also you take response from the cyclophosphamide, which is a prominent lymphocytic cytotoxic agent. So, but the patients have more autoinflammatory pattern, I think.
Thank you so much.
We have another question from the audience.
Yeah,
Henning Kökmen
Yeah.
wants to thank you for your presentation, and she asks, how do you manage cases where neurobehçet patients experience refractory headaches despite immunosuppressive treatments?
Yes, this depends on the nature of the headache. Of course, if the patient has a secondary headache, like secondary to CSVT, so you should reduce the pressure, obviously, and after that, you may have some response. But if the patient has an idiopathic headache, you should just treat the patient same as the other idiopathic headache cases. Maybe we may use more steroids in some unresponsive patients, but we should select the patients very carefully.
We
We
have
have another question. Yeah, Esme.
Yeah, we have a question from Ardalcho. What do you think about anticoagulants in Behçet disease-linked venous thrombosis? Maybe you may summarize.
Yes, maybe this question may be maybe involving the systemic venous thrombosis or other than the cerebral sinus vein thrombosis. So I think rheumatologists are more prone to use anticoagulants in the systemic venous thrombosis cases because of the fear of the, for example, pulmonary emboli from the deep vein thrombosis, I think. But I cannot speak about that so much.
Thank you. We have also, yeah.
I think Dr. Haniye Fatih
yeah,
has a question.
But she lowered her hands, and then, dear Hani, you may also write to the chat your
but you can
question.
also use your microphone. I think she's allowed
Okay,
to
right.
use microphone.
Hi, thank you so much for your great presentation. My question is about how does the prevalence of different primary headache disorders vary in patients with Behçet disease? And is there any difference in, for example, if they have migraine, is there any difference in intensity, frequencies, or other characteristic of headache? Thank you so much.
Yeah, so there are conflicting literature presentations, literature papers about this topic. So some papers report increased prevalence and some report not increased, same prevalence. I think there are some methodological issues, differences in these studies. So it's not easy to answer the question. But in some studies, migraine has increased prevalence. You can see increased prevalence of migraine in bed chest patients, but this is an open question for the area right now.
This is an inflammatory condition where the inflammatory mediators are increased, and it seems reasonable that some headache conditions, such as migraine or other conditions associated with increased inflammation in the
This is one expect you can
This is
expect.
what we expect, yes.
Yeah.
I think we have one last question. What is the role of genetic testing in diagnosing bed chest disease?
Okay, we use HLA-B51 for just supporting the diagnosis, but not exclusively. So the clinical and other laboratory findings are more important in the diagnosis. For now, if you want to exclude hereditary autoinflammatory diseases, like I mentioned about that, so it is important. But the typical patient doesn't need a genetic testing right now.
Another question came.
Yeah. Well, yep. Yeah, I think you see better than me. Yeah, please go.
Okay, the last question. Do you have any suggestions or concerns about the use of triptans?
Can you repeat the question?
Do you have any suggestions or concerns about the use of triptans in neurobed chest disease for headache?
Headache. As I mentioned about that, this depends on the nature of the headache. So in the acute phase, patients may have headache, also parenchymal or sinus vein thrombosis. So you should steroids may help. Actually, but if you are mentioning about the idiopathic cases, so GTBA or migraine, and then this will be the same with the other idiopathic cases.
We will not have any reason to fear from the vasoconstriction caused by triptans.
I think this may be not a major concern. Esme.
Thank you, Tunjai,
Yeah.
it was very instructive and very nice talks. And now I think we may move to the the second part of this webinar concept. And I would like to invite Arife Çimen Atalar, Associate Professor of Neurology at Istanbul Physical Therapy and Rehabilitation Education and Research Hospital, and for her talk about IDEM multi-center study. Please, Çimen, the word is
Thank you, Esme,
yours.
for inviting me to this webinar. In the next 10 minutes, I'll try to summarize our multicenter study about headache in idiopathic generalized epilepsies. Can you see my presentation now? Okay.
Yes.
Okay. I'll try to summarize our study about headache in idiopathic genetic epilepsy. As you know, epilepsy and headache are both common paroxysmal and disabling neurological disorders, and the epilepsy prevalence is about 0.5 to 1%, whereas the headache prevalence is about 46% in the general population. Both headache and epileptic seizures can coexist either in a temporal relationship, as we call them periictal headaches, or independently as interictal headaches. Headache prevalence in people with epilepsy differs from study to study, but reported between 7 to 57%, the majority of it being migraine followed by tension type headache. Both are prototypic examples of paroxysmal brain disorders and have possible shared pathophysiological mechanisms. They may be probably different reflections of altered neuronal network stability or hypersynchronous cortical activity in epilepsy, and cortical spreading depression in migraine might be two different consequences of this altered mechanism. And headache is still an under-recognized symptom in people with epilepsy. Either patients might ignore or choose not to mention to their neurologist, epileptologist, if not questioned specifically. And this is one of the major reasons. As we know, the link between headache and epilepsy might be more prominent in patients with idiopathic genetic epilepsies, which they both might share a common genetic susceptibility. There aren't enough studies focusing on this comorbidity in some selected subgroups, such as juvenile myoclonic epilepsy and focal idiopathic genetic childhood epilepsy syndromes. In this multicenter study, our goals were to investigate the prevalence of headache in idiopathic genetic epilepsies and to cluster patients with regard to their headache features, to give insight to physicians about the correct management of patients with idiopathic genetic epilepsies with headache, and increase the awareness of headache comorbidity in general practitioners and neurologists to avoid under-recognition of a potentially treatable condition in these patients. We had a nationwide and multicenter study between April 2019 and December 2020. 28 participating centers, 809 consecutive patients were involved, and the majority of being female with a definite diagnosis of an idiopathic genetic epilepsy syndrome. Patients were aged between 6 to 40 years with a minimum 1 year of follow-up and a minimum of 1 EEG recording supporting their diagnosis. All EEGs and clinical features were re-evaluated by a panel of experienced clinical neurophysiologists to ensure the idiopathic genetic epilepsy diagnosis. Our data collection were as follows. We had face-to-face interview with the patients. There were 2 questionnaires, one for epilepsy and the other for headache. Detailed diagnostic questions regarding the demographic, clinical, and electrophysiological details of the epilepsy were questioned in the first questionnaire, and if the patient had headache, a second questionnaire was applied to the patients with diagnostic questions based on the International Classification of Headache Disorders 3rd edition criteria for diagnosis of both interictal and periictal headaches. The clinical features of headache and associated symptoms, age at headache onset, time of last headache attack, frequency of headaches, duration of pain, location and quality of headache, family history, and questions about the temporal relationship of seizures and headaches, and visual analog scale scores for headache intensity were questioned. A headache expert among the authors rechecked the diagnosis to ensure the correct diagnosis according to the International Classification of Headache Disorders. The subgroups of idiopathic genetic epilepsies were classified according to the ELI classification as follows: childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with generalized tonic-clonic seizures alone, and genetic generalized epilepsy other. Idiopathic genetic focal epilepsy syndromes were classified as follows: self-limited epilepsy with centrotemporal spikes, previously known as Rolandic epilepsy, and childhood epilepsy with occipital paroxysms. Patients were further grouped into two categories according to their current age at the admission. Adults, 18 years of age and above, the majority of the patients were adults, and children, adolescents, less than 18 years of age. There were about 141 patients, and statistical analyses were applied as SPSS for demographical and clinical variables and unsupervised K-means algorithm for cluster analysis of patients according to their common epilepsy and headache characteristics using Statistica program. This is the flow chart. I'll pass this now to quickly summarize. And this is the distribution of the epilepsy syndromes. And the majority of the patients had juvenile myoclonic epilepsy, about 337 patients, 41.7% of all patients, followed by generalized tonic-clonic epilepsy and childhood absence epilepsy and the other epilepsies, as you see. The most important results, now I'll try to summarize. There were 508 patients with headache among 809 patients. This is about 62.8% of all patients had headache. And the 435 patients were adults and 73 patients were children and adolescents. In 444 of all patients with headache, the headaches had no time relationship with seizures. The most frequent type of interictal headaches was migraine with a prevalence of 41.2%. And migraine with aura, migraine without aura, and chronic migraine prevalences are shown here. And there were also tension type headache patients with a prevalence of 13.7%. And when evaluated separately for age groups, migraine and tension type headache prevalence was 44.6 and 12.7 in the adult group, respectively. And for the child group, 24.8% for migraine and 18.4% for the child adolescent group. There were 105 patients with headaches with a definite time relationship with epileptic seizures, periictal headaches. 42 patients also had accompanying interictal headaches, and one patient had both preictal and postictal headaches. We performed a K-means cluster analysis for these patients, and the cluster analysis classified 443 of 508 patients with headache according to their common headache and epilepsy characteristics. This table shows the whole group, the whole patient group, which were clustered into 3 clusters, as you see. Just a minute. And cluster 1 had patients with frequent and moderate to severe headaches, and the majority had a family history. We can summarize as migraine type headache characteristics, and most of the patients had juvenile myoclonic epilepsy. Cluster 3 had patients with focal seizures and generalized tonic-clonic epilepsy syndromes, and most of the patients had tension type headache characteristics. And there was a cluster 2, which I will mention later, which is a border zone. We call them border zone cluster. This table shows the cluster analysis of adult idiopathic generalized epilepsy patients with headaches. I'll try to summarize this table in the next slide with a figure. We had 2 clusters in here in adult patients. The first cluster involved the patients with juvenile myoclonic epilepsy, seizure types as myoclonia, and generalized tonic-clonic seizures. With more than equal or more than 5 headache attacks, equal or more than 1 hour of headache duration, throbbing headache, family history of headache, and VAS score more than 5, and headache duration more than 24 months. And the second cluster had SLECs and generalized tonic-clonic seizures alone, with less than 5 headache attacks, less than 1 hour of headache duration, non-throbbing headache, no family history of headache, VAS score less than 5, and headache duration less than or equal to 24 months. And we had another cluster analysis for child adolescent group, and I'll try to summarize this in the next figure. Child adolescent group also had 2 clusters. The cluster 1 had focal seizures, less than 5 headache attacks, less than 1 hour of headache duration, non-throbbing headaches, no family history of headache, VAS score less than 5, and headache duration less than 24 months, whereas the second cluster had myoclonia, more than 5 headache attacks, more than 1 hour of headache duration, throbbing headache, family history of headache, and VAS score more than 5, and headache duration more than 24 months. If we summarize our results, we can say that headache is a very frequent symptom in people with epilepsy with a prevalence of 62.8%. The prevalence of migraine was very high, 44.6% in the adult patients, which is obviously higher when compared to the general population. Headache prevalence of 51.77% and migraine prevalence of 24.8% in our pediatric group confirmed the higher prevalence of headache and migraine comorbidity in children with idiopathic generalized epilepsies. Patients with idiopathic generalized epilepsies can be clustered into distinct groups according to their headache features along with their seizures. And there are 2 clusters for both adult and children group in terms of headache features with their epilepsies. Here I summarize the results that I mentioned before. In adults, subjects having a family history of headache, more than 5 headache attacks, duration of headache for more than 24 months, longer headaches, and visual analog scale scores more than 5 were grouped in one cluster. And subjects with juvenile myoclonic epilepsy, myoclonic seizures, and generalized tonic-clonic seizures were clustered in this group. Self-limited epilepsy with centrotemporal spikes and epilepsy with generalized tonic-clonic seizures alone were clustered in another group with the opposite headache characteristics. For children, the same features as in adult cluster 1 were clustered in a separate group except for the presence of juvenile myoclonic epilepsy syndrome and generalized tonic-clonic seizures alone as a seizure type. And the focal seizures were clustered in another group with the opposite characteristics. In the entire group, the first table that I showed you, the model revealed an additional cluster, including patients with the syndrome of generalized tonic-clonic seizures alone, with more than 5 attacks, headache lasting more than 4 hours, and throbbing headache, and 65.66% of patients had a family history of headache in this third cluster, which we have called a border zone transitional group. We believe that the cumulation of patients with juvenile myoclonic epilepsy with migraine in a separate cluster supports the hypothesis that an endotype with headache exists in patients with idiopathic generalized epilepsy with a stronger genetic susceptibility. This shared genetic liability may lead to a neuronal hyperexcitability state, as the triggering of cortical spreading depression may eventually facilitate the onset of a migraine attack or epileptic seizure, depending on the type and velocity of the propagation, as the recruitment of trigeminal nuclei can result in central sensitization and pain for migraine, or synchronous firing of larger neuronal populations followed by an epileptic seizure. Milder non-migraine headaches were accumulated in a separate group and were more closely associated with focal idiopathic epilepsies and SLECs and GTCA. Focal seizures were accumulated in a cluster along with mild, moderate, and shorter headaches. Thus, children with idiopathic genetic focal epilepsy experience less disabling headaches, we might say. Of course, our study had some strengths and limitations. The recall bias of the patients about the details of their headaches and seizures is a limitation, but all patients were regularly followed up, and the available data of each patient were rechecked by the physicians. Another limitation is the smaller number of child and adolescent patients when compared with the adult patients, owing to the limited contribution of child neurology centers and experts. The main strength of our study is the confirmed epilepsy and headache diagnosis based on the specified tertiary center data by experts. And another strong point is that comprehensive data set, including potential bias comparisons and checking all of the required developmental and comorbid issues. As a conclusion, this study is the first attempt to categorize patients with idiopathic generalized epilepsies in clusters concerning the different characteristics of their headaches. Patients with migrainous features may require carefully selected anti-seizure medications and other treatments, effective also on their headaches rather than over-the-counter medications, whereas other patients can benefit from regular medications and daily life regulations. And of course, we need further studies addressing the association of headache and epilepsy comorbidity to uncover the hidden mechanisms and genetic links which could further improve our treatment options. Thank you for listening to me.
Thank you, Dr. Çimenetalar. That was very nice talk and very inspirational work. And your sample size are also huge. We have a comment from Hani. Dr. Atalar's presentation is perfect. She has written, and until now, yeah, she get all the answers to her questions. She raised her hand during your talk, and now, yeah, thank you. And I would like to thank all our speakers for their comprehensive and instructive talks. And Behçet disease is one of the important autoinflammatory diseases, and headache occurs in a remarkable proportion of patients with Behçet disease, and 20% in 20% of Behçet disease, cerebral venous thrombosis occur, and rarely there are also other secondary headache conditions such as pseudotumor cerebri or aseptic meningitis may also be seen, and oral anticoagulants in cerebral venous thrombosis related to Behçet disease is not the first-line treatment in Behçet disease, and we should consider the steroids first. And in some difficult cases, they may be an option, but we should be cautious because of the several aneurysm in the pulmonary system. And now we will I will give my word to my co-host Doğa to make that.
Thank you, Esme. I want to thank all of the guests for this great night where we talk about neuroBehçet disease and headache in epilepsy syndromes. And I also want to thank our audience for listening to us, and hope to see you again in our next webinar. Thank you.
Thank you.
Thank you again. Bye.